Hi, greetings from Western Australia. I'm so glad there is such a focus on family caregivers in this session. And I just need to ask everyone, is this how they do it? So I'm Professor of Palliative Care and also the Vice President of the Motor Neuron Disease Association in Western Australia. Sarah, how do you do it? Sorry. Just next. Here we go. Yeah. Okay, I got it. Thanks. So really in palliative care, we try to really achieve the best quality of life possible, not just for the patient, but also for their families. And research has shown that if you support people when they are caregiving, they've got better outcomes also post-bereavement. And here we go. I'm going to talk about another carer assessment tool called the Cessna, which encompasses the physical, psychological, social, practical, financial, and spiritual support needs that government policies emphasize should be assessed and addressed. So these are my partners who, together we developed the tool, particularly the UK people, University of Cambridge and University of Manchester. And we've looked at some systematic reviews to start off with regarding what are the needs. I led one on family caregiving for motor neuron disease. And then we thought, okay, now it's about time we do interventions. We know that there is a lot of need there. And so when the Cessna was developed, was really to look whether it improves perceived support, psychological well-being, physical well-being, burden, bereavement outcomes. There are two sets of items there, the enabling items and the direct items. The enabling items is what all services do. How do you enable the carer to care for the patient at home? The direct ones, everybody says we do this, but they're not really doing it. These are what do the carer need for themselves to keep them going, basically. And really it's very simple. They just answered no, a little more, quite a bit more, and very much more. So this is the enabling items: understanding your relative's illness, knowing what to expect in the future, knowing who to contact if you're concerned, managing your relative's symptoms, providing personal care, equipment, and talking to your relative about his or her illness. The direct ones: looking after your own health, dealing with feelings and worries, beliefs or spiritual concerns, practical help, financial, legal, work issues, having time to yourself, getting a break. So this has been developed from a lot of focus groups and interviews with family caregivers in the UK. Then it's carer-led, so it's facilitated by the service provider, but the carer actually ticks on the forms what is it they need help with and what are the 3 priorities that they need to discuss when the service provider comes to see the patient at home. So in a way, they're looking after 2 people, the patients and the carer. And then they advise on the actions identified. So the key here is to have interventions that are integrated into existing practice, not really working alongside existing practice. It doesn't work. And this is what we tried to do with this intervention that I tested in Australia in community palliative care. We really needed this intervention to be relevant to family carers, to the service providers, to fit in service practice. And the most challenging thing was the changing behavior of service providers. So we conducted a step-wedge cluster trial, and it showed significant decrease in caregiver strain for family caregivers, but this is like for caregivers of people who are at end of life. Again, we had 233 family caregivers who basically were overwhelmingly support for the tool. And again, the 44 service providers were really very, very interested to embed it in routine practice. So these are the sort of articles that have come out of the publications to give you a good idea about what the Cessna is about. And so what we did now after that, we thought, okay, well, let's see if we can take it to other settings now. And I sort of piloted this in Perth with the Motor Neuron Disease Association in Western Australia. We had 30 family caregivers and 4 care advisors. The intervention was about 2 visits from care advisors 6 to 8 weeks apart, and we obtained family caregivers feedback and service providers. This is basically the tool. It's very simple. The blue part is all these Cessna items where the caregiver ticks, and then the orange one is, or pink one, is where the priorities are set and the discussion is taken around what support they needed for that particular session. So we had 24 family carers who completed the study within the 4 months with pilot study. The median time was about 7 weeks. Face-to-face or phone, both worked well. If the family caregivers, if the care advisors couldn't get to the homes within this time period. Again, as Steve said, the mean age is 64 years, 75% are females, and so on. In terms of the caregiver demographics, the patients were 71% male, again, mean age 63 years. And we looked at the ALS functional rating score, and the median was 27, which is sort of middle of the functional ability. Okay, so what do carers for MND need? These are the top 5 priorities if you go from the top. Knowing what to expect in the future, knowing who to contact, equipment to help care, dealings with your feelings and worries, and having time to yourself in the day. So quite a few of them are what the carers need for themselves, not just only to be able to look after their loved ones. And as you can see in the second visit, some of them had got less because they were taken care of, and some of them became more prominent because as the disease was progressing, the needs, some other needs were taking place. The 2 things that we need to look at in a larger trial, one item on communication, and this has come really from 2 people. We need to look at communicating this with other family members to help them cope with the illness and the progressive decline. And also one carer said, how can he communicate with his wife who lost her speech and feels quite isolated from the wife? But we can't change any items till we do a larger trial, basically, to see whether we need to adapt the Cessna to this. So for example, for the first priority, knowing what to expect in the future, the care advisors discuss end of life with MND, and also referral to palliative care should be made. In terms of the second priority, knowing who to contact in the future, again, the carer is beginning to be more anxious, and they started a plan, ambulance cover, and again, palliative care services. So this is the kind of actions the care advisors were able to put in place to help the carers. And this is the 4th priority, dealing with your feelings and worries, sort of what they encourage them to do, go to counseling or organize that for them. Okay, so what did the family carer say about the Cessna? 83% found it really easy and very easy to complete, and it really, most of it addressed their needs except for that communication support thing. So these are the carers' key themes: the overwhelming caregiver journey, the Cessna practicality and usefulness, validation of the caregiver role in empowerment, and reassurance of support. Just a few quotes, basically. For instance, this is what they're saying about the overwhelming carer journey. I do have to go and see a shrink. It's very stressful at times. They should bring in euthanasia. You wouldn't put a dog through what MND does. I find it really difficult. It really rips you apart. So in terms of practicality and usefulness, it's a really good form compared to the other one, really easy. I was given the first form when it was early stages, and I didn't think I needed much. By the time the second form, MND had progressed, my needs changed, and the questions were more about what I needed then. So it was really good to talk to the care advisor. So it's opened that discussion. Practicality and usefulness, again, they're saying the form was really well done. It covers everything. It puts those little stars up there to consider. And the way it works sort of with the 2 sections of the form was very much appreciated. The role and empowerment, the form made me think the role of carer was important. The fact that we've been asked shows it is considered important. The form shows some evidence someone is caring to ask. So it was really important to let them know this is about you, this is not about the patient this time. They jogged them thinking about all the needs that they really needed to start considering. I just skipped through all this. If anybody is interested, I could send you the presentation. So reassurance of support, the care advisors, they know about the disease, whereas friends don't have an understanding of MND, so even just talking with the care advisor is a help. And then they felt that the support was kind of very timely and immediate, basically, when they started getting the help and telling about. Anyway, one of the hardest issues to discuss was end-of-life issues, and this is what basically helped them to start talking about this. So what did the care advisors think about the Cessna? So these are the lovely 4 care advisors in Perth, and basically their background nursing or physio. It helped to identify some issues that perhaps you wouldn't come up in the normal home visit or phone call. It's been a springboard in several instances to allow a carer to explore their needs. Good opportunity for the carer to be acknowledged and able to verbalize their fears. It made me realize that it paid to ask the question, even though I thought sometimes I knew what the answer would be. The support provided as a result of the Cessna, it does assist in providing a holistic approach to carers' need. It opens up doors for that. We all do a pretty good job and have good awareness of supporting carers. It does let the carer be the focus of this support. It can uncover areas which may not have been recognized or adequately dealt with. It can highlight support providers. It also acknowledges the important role they play. What are the challenges for these care advisors? Finding the right time. There were instances where there had been an outpouring of issues. With a greater time period, it may have been easier as my contact with the carer would have been increased. Had trouble fitting in the Cessna due to existing workload as a care advisor. Mind you, we only had 4 months to do the pilot study, so if we had given them more time, that would be easier for them. Sometimes when I planned to do a visit, it wasn't always appropriate because there were other pressing needs or issues. Need to catch the carer in the right emotional space to participate. Regarding reviewing of the carer needs, because they do it again in another visit, it offers an opportunity to allow the focus to be on carer and allows them to have a safe place to consider their needs. I think it's interesting to see how carer needs change over time and that their needs don't always follow the same trajectory as the person with MND. Sometimes what I perceive as a very stressful time for the carer, they seem to sail through, whereas something minor for me at another time can unleash a great emotional tide for the carer. Perhaps not always in such a formal way, but as a template for the care advisor to check off that they have taken all carer needs in consideration. So we asked them then, so was it improvement to standard practice? Thinking about the work we do and finding ways to put processes in are always an improvement to standard practice. Yes, because it emphasizes the role of the carer and how the illness impacts on the whole family. Yes, I think it's more comprehensive, provides a structured follow-up process, and there are aspects that are measurable. Yes, in the sense that it formalizes the process and provides a means of documenting carer needs. The optimal stage to actually introduce this, not at the diagnosis time because it's really a highly emotional time, but they think towards sort of the middle stage would be the best time to actually introduce this. Again, 6 to 8 weeks would be a good time to do this, to review. So as a final reflection from the care advisor, if the time is right, the discussion points can have an immediacy that works very well. At times, though, even with the best intentions from all parties, it's often the person with MND whose needs are addressed first. It's good to be constantly reminding ourselves that the bigger picture of care and family support have an equally important role. Once again, I think our role is unique in that way. So really, where to from here now? The focus really for me is a translation into practice and in other settings. So we've done it in community palliative care. We've done the pilot in MND. We're doing one in dementia now, hospital setting, brain cancer, and indigenous field. The Barwon Health, which is in New South Wales in Australia, they actually put it on their website. Basically, so when the client comes to the service, is admitted, the carer is given a website to go to and look at the Cessna items. They just, punch a button there, and it gives them the information that they need. So when the nurse or the care advisor comes home, they can discuss what they need. They've had a look at everything. So yes, acknowledgement to the care advisors, the family carers, the MND Association for facilitating the study, and for my university for funding this. Thank you.
Thank you very much. This is now open for questions. Actually, I had a question while they're getting the microphones. I apologize if I missed it. How long does it take then to actually ask the questions on the questionnaire approximately?
Well, 10 minutes it's taking them.
Oh, 10 minutes.
Actually do. Yeah, it's really quick.
No other question? All right, I actually had another question then. Oh, Rebecca has one here.
Oh, she's right behind you.
Rebecca Axline from Houston, Texas.
Hi.
Hi. Just a quick question. You mentioned that you don't think it would be appropriate to bring up at the time of diagnosis because of the emotional time, but I'm wondering if you would consider just putting it in the mix to start the thinking to explain to the caregiver. At some point in time, someone may be talking to you about what your needs might be. Sometimes those little threads can be very powerful. I don't know. Have you thought about that?
I agree with you. My own personal feeling, it should start from the time of diagnosis, but it's the care advisors who basically felt, see the distress of the carer. Some, health professionals find it really difficult to cope with, and they tend to sort of pull back and find the right time to do it. But, in palliative care, we always say we need to start everything from the time of diagnosis, particularly when we know it's a terminal illness. So whether this is their opinion, but it's just 4 care advisors who said that. So that's why I'm really interested to trial it on a larger scale with other countries, just to see the range of opinion that we have around that.
Actually, I do have a question. I'm Lisa from Northern Ohio chapter. I might have missed this, I'm sorry. What kind of background or training do the care advisors have?
3 were nurses and 1 was a physiotherapist.
Okay.
And it sounded like, over here, it sounded like just acknowledging that you were going to be asking the questions was important for the carers that time.
This is the simplicity of the tool. It's got all these items that a carer goes through, and it sort of works as an early intervention. So the carers, it sort of gives them an idea what to expect is coming their way instead of being totally, surprised by it. So, whether some of them, if you do it early enough, will feel overwhelmed that, oh my God, this is what's going to happen to me. And some of them, this is in the community palliative care, some of them thought they had it too late, and they would wish to have it earlier from the diagnosis stage. It would really help them to plan better, what's coming their way. Yeah.
Any other questions? Here in the...
Mary Rebar, Oregon Chapter, ALS Association. Could you pull the website back up where you said that it is placed on the university website so that we can write down the...
You mean the health service that actually put it on their website?
Yes, please.
Yeah.
Thank you.
Maybe back. It's sort of, it's now. Is this the quickest way of doing it? I don't know. Just like So this is a palliative care service. And I was really thrilled to see that they're actually now putting it into practice. And when I asked them how is it going, they said it's fine. Really, the carers are using it quite well.
Like this. This is how fast you're
There you go,
supposed to
there you go, there you go, there you go, there you go. Here we go, yeah.
All right, everyone take a photo. Any other questions? Oh, way in the back.
Is the actual scale going to be on the accessible website?
The presentations themselves are being videotaped with the PowerPoint. So, I mean, you can go back, actually last year's were up as well. So this will all be on the Alliance website, yes.
And the articles I mentioned have got the tool there, so if you want to have a look at it. It's really good because before I came, the MND Association, they told me in Perth that they really now want to have it as their routine practice and start getting the care advisors to administer it in their visits. So that's a good step forward anyway.
Hi, good morning. I'm Marcela Santos from the Columbia Association of ALS. I want to congratulate you on your project. And just a quick comment, we found in our national university in Columbia that actually the caregiver deteriorates faster in health than the actual ALS or chronic disease patient. So just a comment of that, because they think they don't have time, or they think and they claim that they don't have time to go to the doctor. There is no time to get sick. So everything is just towards the patient, and actually they get another chronic disease, and they die even faster than the ALS and chronic disease patients.
Sort of a few years ago, I've written an article calling the carers the hidden patients. whether, you know, in palliative care or any of the other terminal illnesses. So, and again, the other article I wrote, you know, family caregiving for the terminally ill, at what cost? And I've mentioned all these costs, basically, the physical, the mental. It's very, but you know what happened is this, we keep talking about this, but there are very few interventions that are happening to make a difference. And this is why I like this tool, because it had made a difference for caregivers during caregiving, reduced their strain for the intervention group compared to the control group. So it's really been, the effectiveness have been trialed. And it's just a matter to see whether it will have the same, effect in the MND field now. In dementia, the interesting thing about it, as soon as the carers read it, they made immediately changes to their life. One of them had put their loved one in daycare longer time than they were giving when they looked at, you know, it sort of made them really reflect on their needs. And another one, I'm not advocating this, but it made her decide to put her loved one in a residential aged care because just she couldn't take it anymore. So they are making changes to their life and being proactive and sort of not trying to suffer for so long so that they die before the patient, as you said sometimes.
Yeah, we actually have a program in Colombia, Caring for Caregivers, and we would love to share it with you anytime.
That would be lovely, thank you, yeah.
Okay. Thank you very much.
Okay.